Of course, the goal will look something like this at the end. Calm, poised, ultrasound guided, sterile, rapid. All of those things will be actualized after you sink your teeth into this material and get some hands-on practice.
First micro skill is learning syringe manipulation in the setting of being able to withdraw the plunger back. Because once you enter through the skin during a central line, you're supposed to be exerting constant negative pressure on the plunger. At the same time, you're able to move in and out, change your direction depending on what the ultrasound is showing you. And you have to be able to do that. So the finger motion is thumb on the plunger, and then I have my index finger and middle finger on the, I should say the index middle finger on the plunger and the thumb on the actual extrusion of the syringe itself.
It's also critical that you gently apply aspiration while advancing the syringe. I recommend the following technique. Hold the barrel of the syringe firmly with the thumb, index, and middle fingers, and curl your ring finger around the flange of the plunger. Pull back on it gently and constantly with the ring finger as shown here.
And so what you need to be able to do is stabilize the needle in such a way that there is no movement at all of both the needle tip in the vessel causing vascular trauma or the hub that might push the needle in a little bit further, and now you won't be able to pass a wire or actually pull it out of the vessel itself. So very similar to the bridge you use when playing pool, you want as maximally stable as possible. And when you look at a good pool player, they're always going to have as much of the hand in contact with the felt as possible, because that's going to give them the most stable bridge. And whether they have an open bridge or a closed bridge, you'll always see that their entire hypothenar eminence is touching the table. Again, place your hypothenar eminence on the patient's body. That's the equivalent of the pool table felt. And what that's going to do is a few things. It's give you a stable base. It's also, if the patient moves while you're trying to do this procedure, your hand is now a part of their body, and the hub of the needle will stay in its stable position even as the patient moves back and forth. Touching the patient, beautiful stable base, thumb and index finger at the hub of the needle. It's actually a twisting motion. People seem to think that this is the lure lock on these, and you should not be using lure locks in general. You should just have a slip. So it can just be a pull, but I find it's a lot harder to disengage that. So I always just do a little twist. And you should just practice time and time again, a couple hundred, couple thousand times, to the point where you can disengage the hub of a needle without causing any movement to the hub.
Now,
and when
what I see people doing all the time is they do the air stabilization thing. If there's any patient movement or hand movement, that's it. You're going to lose that needle tip in the vessel. So lock yourself to the patient. I prefer an overhand grip, and just like I'm playing pool, when I'm going to do a pool bridge, I will put my hypothenar eminence on the patient and stabilize that way. And now I am
out of a packing area. I don't know if that's showing well. It's right there. And that's designed so that the wire does not move. Its whole purpose is to keep the wire from moving. That's going to be deleterious to you moving the wire. So step one, whenever you get one of these, is to actually pull it so it's disengaged from that little packing area. And then you straighten out the J tip. And I actually like to advance just a little bit of this wire for a reason I'll show you in a second. Now you guys might be used to the ones with the little thumb indentations where you don't have to manipulate the wire as much. Learning that is great if that's going to be your kit for the rest of your life. But if you're ever going to run into a kit like this, and I promise you you will, I think it's worth learning it this way, and then you could always adapt to the other one, but not vice versa. So managing this kind of wire where they don't have that little thumb situation, I think is advantageous, because then you can use any kit. So the micro skill is you now practice adding in, disengaging your hub, taking the wire, and the idea behind this is to put the wire in the hub in such a way that your first advance gets you very close to being outside or even outside the tip of that needle. Because once that tip of the wire is in the vessel, you're in good shape. Now the next move is to pull back on the entire apparatus. Then re-grab with your thumb and index finger, and again push forward. Pull back, push forward. If you need to withdraw the wire, which is always fraught with peril, but if you decide it's a good idea, then you'll pull back and then advance the whole apparatus. And there'll be some friction in a real patient, so this will not go back into the patient. And you can just keep doing that until the wire is now back into your initial wire thing. And that's really the hard parts of central line placement. Those are the micro skills worth learning. The rest is just understanding the procedure. Now there's a few bonus micro skills. For instance, if you lose this thing, well, now you're stuck with a J-tip. And you could do the ridiculous manipulations where you try to turn it upside down and, you know, force it in there, and it's annoying. And that's not the way it's done. And I should say, you can use the back portion of the wire. It's not as safe, but it's still not designed to protrude through the vessel. This is acceptable, and sometimes you have to do that. But the J-tip is safer because it's actually a rounded edge hitting the vessel wall. So what do you do in those circumstances? Well, you want to straighten the J-tip. You want to straighten the J-tip. Now, this is kind of tough to learn, and I'm going to try to explain it. And what you could do is if you hold the wire steady, you could actually advance the coil while leaving the wire stationary. So the movement is, you actually grip the wire portion at your hypothenar eminence with your pinky and ring finger, you know, digits 4 and 5, and you lock it to your hand. So now it's locked to my hand. Now with my thumb and index finger, I advance the coil. And so that's the move. And now this is nice if you lose that blue thing. You know, you have your hub there and you've lost your blue thing. Well, oh, no problem. I got a straight, you know, wire right there that now I could advance. And in some kits, it's actually easier to just take the whole wire out of this holder, especially like when I'm doing femoral A-lines. I just want the wire free. I don't want it in anything. It's a manageable length that I could handle it. And sometimes that blue thing gets lost. So learning this micro skill of wire straightening.
So if you ever lose the little blue thing, lock the wire with your pinky and ring finger, and then advance the outer core of the wire to straighten your tip. And Rob did that quite adroitly. Run with it, buddy.
That's the word of the day. Okay, here we go. Pull that off.
And now they're meeting resistance. Now, what you could do is push through it, because that works out well for you. But they're going to keep going.
There it is.
Now, what just happened? Well, let's show them what it's going to look like when it comes out, and then we'll talk about what happened.
Pushing against resistance.
Yep.
And there wasn't much resistance at that time.
No, it doesn't take a lot. All right, so you got a fully kinked wire, and now if you try to dilate against that, you're going to be hosed. You can't push against resistance. And sometimes you feel it and you think it's just a needle tip up against the vessel wall, and if you push a little bit further, it's going to work, and fine, you're going to gain skill at that. But in general, if you're hitting resistance, come out, readjust your wire angle, readjust where the J-tip's pointing, give it a little rotation, go back in. Don't push against resistance, because if it goes and you feel good about yourself, you might have just punctured the back wall of your vessel. Now, these are flimsy wires. They'll kink instead of puncture most of the time. As you get thicker wires, you'll get past the resistance, and you'll do it at the expense of the aorta or the IVC. So any resistance, pull back, and then go in again. All right, Rob. But now you'll be able to do it easily. Okay.
How we do it.
Yes,
right?
so notice
Kinda
the
like
first tip here is Rob threw something on the floor.
Yeah.
You're not allowed to do central lines unless you're throwing items on the floor.
Here you go.
Thank you.
All right. So we got the warning indicator. I don't know what it's warning us against.
Yep.
All right.
Now, what is Rob already doing wrong? Now, Rob, what hand is dominant on you?
It's my right hand.
Yeah, so this has to be here. So always position your trays on your dominant hand. This allows you to maintain, for instance, needle in the vessel with your non-dominant, and actually get your stuff without doing this or this.
What is essential?
So my residents take like a half hour to do central lines, and they're very skilled, and the problem is they prep stuff they don't need to prep. So the 3 things you need on every line, for instance, a crash central line, is you need your needle and syringe.
Needle and syringe.
Just take off that cap, and that's
sterile.
it. That's all you have to prep. Now, if the patient has pain perception, then you want to get local anesthesia ready as well. But don't flush your lines, don't do all sorts of stuff, don't put on the blue caps now. That's all wasting time. That could all be handled after you get the line in. This is all you need.
The wide area, including the clavicle and up on the neck, following your local guidelines. While waiting for the chlorhexidine to dry, prep your tray. Place your equipment in the order you will be using it, and make sure to loosen all needle covers. Everything should be easily accessible by one hand, since you do not want to move the probe once you've located the perfect ultrasound view.
Rob, what are you doing, man? No. So these wires, stop. Okay. So these wires they're more than long enough that you should never have that little wire out. They always are sized so a significant portion of the wire is out. So, you should be, enough of the wire out so that when you put the actual line on, you don't have to do much of that, feeding the wire back. So generally this much out for something like a central line.
Okay, now I'm happy with this.
Yeah, that looks good.
I'm gonna take my needle out.
All right.
Can I let go of my wire?
Is
that safe?
Honestly, the magical sucking into the vessel doesn't happen, but it's paradigmatically good to keep that foremost in your mind because it's a good basic idea to not have evil happen. So always have a hand on a wire is not true, but it's useful.
Okay, here we go. Okay.
Now, you got to check your work. And this is really the first key move here. Is I see people dilating at this point. The problem is, very frequently, there'll be a skin bridge between where you made your scalpel nick and where the wire's actually entering from the needle. And that skin bridge, when you try to dilate against it, will just destroy your dilator tip, potentially kink the wire. So you have to check your work. How do you check your work, Rob? Yeah, so Rob's making a circle with his wire, and what you want to see is the nick you just made, you want to see it moving within that circle. If you try to rotate the wire and it's not even close to the nick, then you have to make your nick again. Let's see the videotape on this. All right, so there's the nick, and then you rotate the wire in the nick you just made. And if it rotates inside the nick, you know you're in good shape. If not, you got to recut with your scalpel.
Okay, so if you have a skin bridge, recut.
Recut, exactly right. All right, now we're up to dilation. And this is where I see a lot of EM, critical care folks messing it up because we were never taught the right steps of dilation.
In this patient. And so what do you do once you get flashback? How do you ensure that you're not in the carotid? Well, the best thing to do, of course, is to put the guide wire in before you cannulate, and then look to see this hyperechoic stripe nicely penetrating through the IJ. So we'll do this once more. It starts in short axis, and then you turn your probe 90 degrees to the long axis, and then there you go. You see the guide wire sitting in your vessel.
Insert the guide wire in the usual fashion and confirm its correct position by identifying a hyperechoic line in the subclavian vein. Next, move the probe to the neck. If the guide wire has deviated cranially, this will be seen as a hyperechoic dot in the internal jugular vein. This is readily apparent in this sequence from another patient, where we were able to immediately retract and reposition the guide wire. Tilt the probe caudally and keep the jugular vein in the middle of the screen to find where it merges with the subclavian vein to form the superior vena cava. With this maneuver, the correct guide wire position can be verified. Note that the hyperechoic medial pleura, marked in green, may have a similar appearance as the guide wire, and for the novice, this is a potential pitfall. Proceed with the central line in the usual manner. Then further confirm the venue's placement by observing the height of a non-pulsatile blood column. We're currently performing a validation study, but we believe that most post-procedural X-rays will be redundant if the guide wire position has been confirmed using this technique.
And now there's many things wrong with what Rob's doing. The first thing is, look at where he's holding. He's way back from the skin. This is going to cause bends in your actual dilator, and all of your force, if there's any resistance here, is going to be transmission to the shaft of the dilator instead of the tip, which is where you want it. So let's readjust your grip. Yeah, so now you're close. You're about an inch, a couple centimeters away, and I prefer to bunch my 3 fingers.
Dominant hand?
Yep, dominant hand on the dilator, and then aim my index finger where I want it to go. And this allows me to do gentle little pushes along the wire. Now, Rob, when he started, had an angle like this for the sake of this example. Now, that's also problematic. You want to match your dilator angle to the needle entry angle. And generally, I'm going at a 45-degree angle on my needle entry, so the dilator is always going to stay at a 45-degree angle. We have a tendency to move angles as we're dilating, and that will destroy the wire. And if he meets resistance, he's going to do what's called racking. I don't know why this is called that in the vascular, when I was taught by vascular surgeons. That's how they described it. I can't find it in a dictionary anywhere. But racking is a gentle insertion, pull, 1 centimeter in, 1 centimeter out. What that tells you is that the wire is moving freely in the vessel, that your dilator has not jammed the tip of that dilator against the vessel wall. If you try to dilate when it's jammed, you could puncture the back wall of the vessel or kink your wire. So now Rob's only going to advance further on the dilator if he's able to rack. So 1 centimeter at a time, check, go in.
I can't. It's actually a lot of resistance right now.
Okay, when you reach resistance and you can no longer rack, then you need to pull back on your dilator because you're right up against the vessel wall. You're about to back wall and kink. And now, adjust your angle, make sure you're still at 45, and see if you can still rack now. And now you're allowed to go in. If you're reaching resistance and you can still rack, you're allowed to go further. If you're reaching resistance and you cannot rack, you cannot go further on your dilator. You need to pull back on your dilator, readjust, and try again.
Okay, I'm going to do some review.
Yeah, let's do a little. And now you're racking to check if the resistance is something you can push through or you have to stop and readjust.
Thanks, bud.
So that's key, is push and rack. That's
Next
step
slide,
one micro skill. And now look, dilator angle, go back one. Dilator angle equals wire angle. If you entered at 30 degrees, you can't dilate at 90 degrees. You're going to kink your wire. One more forward. All right, and notice overhand grip close to the skin that allows you to put that gentle force and reminds you cognitively you're only going in 1 centimeter at a time. Now, you could get away with really shitty technique, sorry for that, on a 7 French dilator. Like, I could just jam that in like I just did, and you'll get away with it. You might think you're a superstar at central lines. You try that with a dialysis catheter, or what's worse, a 14 French for a percutaneous pigtail in the chest, and you will destroy the wire and dilator and potentially parts of the patient's body. So learn to do it right every central line so that when you're on a big line, you don't get it wrong. Now, what happens if you just keep reaching resistance, but it does still rack?
It's racking.
But it just can't get past it. You're trying, you're worried you're going to do something evil. At that point, you need to rip the subcutaneous tissue, and that's the next micro skill, and it's called twist and rip. And what Rob's going to do is he's going to make sure he can still rack.
Racking.
Good. And now he's going to put gentle inwards pressure.
So pushing in.
Yep. And now you're going to twist that dilator to actually wrap subcutaneous tissue around the dilator shaft.
Like how many times do I twist it?
4 or 5 times until you can really feel a lot of resistance, like it doesn't want to twist anymore. And now rip it out.
All the way out?
Yep, about an inch on that dilator. Pull back. What that's going to do is rip all the tissue that was wrapped around that dilator. Now do it again. Push in until you reach resistance. Rack your wire. Twist, twist, twist. Get a lot of, you'll know it's there because there's friction on the twisting now, and then rip it out. Each time you rip, you're ripping the subcutaneous tissue and making your tract further and further along. And you'll keep doing that. You'll push in, rack, twist, rip, go back in until you're in the vessel. That's the twist and rip. Let's review it. All right, so gentle inwards pressure, check with a rack, and now twist the dilator until I can really feel tissue wrapped around it, and now rip it out. I guess we don't have the ripping it out, but that's okay. All right, so now the next step. Yep, perfect. All right, so now let's say you've gotten the dilation all the way in.
Okay.
Yep. And you can go all the way in. You'll know when you've lost resistance and you're in the vessel. You don't have to go all the way in on these dilators.
Okay.
Another key point is that counter-traction on the skin must be applied with the non-dominant hand when inserting the dilator over the guide wire. If you allow the tissues to buckle or the catheter to bend, the wire may be kinked. At no time must the dilator be allowed to bend as it is advancing through. Hold it along its shaft, not at the hub, and make short corkscrewing motions to advance the dilator cleanly through the tissues.
Now, the taking it out is important too. This is the pinch and pull. Rob, do it wrong. Just watching it gives me heartburn.
Satisfying.
Right, so the problem with these dilators is the 7 French, you'll get away with it. But on big dilators, the friction of pulling it out will yank your wire out of the vessel and potentially yank the entire thing out like a ripcord. So the way it's done is the pinch and pull. You pinch, about an inch away from the back of the dilator, and then you pull to your fingers. And now you re-pinch about an inch away, pull to your fingers. Re-pinch, pull. And this is keeping...
And I'm grabbing up here at the...
Exactly right. And this is keeping the wire stationary in the vessel. Yep.
Okay,
great. All right, let's review that. Leave that in, Rob. I want to show them one more thing after this video. All right, there's the pinch and pull. You pinch about an inch away, inch two, and then you pull towards your fingers, re-pinch. This keeps the wire stationary. All right, one thing that we don't have a video for, Rob, but I think it's absolutely key. I realize now we have to get this point across. I see people dilating without either holding the wire or they're holding it, but they're letting the wire move as the dilator goes in. They're letting the dilator pull the wire. You can never do that. The wire needs to never move. The wire stays stationary. Only the dilator is allowed to move on the wire. So you have to lock that wire in space, and the dilator moves in. The wire never moves. If you're allowing, especially with big dilator setups, your wire to come in with your dilator, you will backwall the vessel, because the only thing keeping you safe is the fact that the wire is being forced into the center of the vessel and the dilator is moving on top of it. If you allow the wire to move with the dilator, you will backwall the vessel on something like an HD cath, or if any of you are doing ECMO.
Okay, let's quickly see this in real life. This is a pigtail placement. You can see he's twisting, and now look at all that tissue that's getting torn as he tears that out. Re-advance. Rack, twist, 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 rip. Re-advance, twist, 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 rip. And each time I'm doing that, I feel stuff ripping with the withdrawal of that dilator. And this is the way that you get through tough muscle with huge dilators. And there's no situation you'll feel this more than when you're putting in either that pigtail or the percutaneous chest tube. You will feel each time huge amounts of fibers ripping as you twist and rip. Okay, now eventually you will get all the way into the patient's vessel or into their pleural space. We'll do one more twist and rip here. And that should get us through. Yep, we are now through. Now, the next technique is called pinch and pull. And this is how to take a large dilator out off a wire. And pinch and pull involves pinching the wire maybe, 4 or 5 centimeters away from the back of the dilator. You pinch, and then you pull towards your fingers. And then you re-grip with a pinch, pull. And what this does is it keeps the wire from bowing, and you're not going to be able to see it on this, but when you get these long floppy wires and these long dilators, if you do not pinch as you pull, the wire could actually get pulled out or bowed or all sorts of stuff you don't want. So the way you take dilators out is you pinch and you pull towards your fingers, pinch, pull. Those are the techniques that make up the micro skill of dilation.
Now grab that dilator and feed it over the wire to get it to the skin. Applying firm but steady pressure, and with a bit of a twisting motion, dilate the skin and the subcutaneous tract. A couple notes about dilation. 1, you only need to insert the dilator up to the anticipated depth of the jugular vein, which is usually no more than 3 to 4 centimeters. And 2, you need to prevent kinking of the guide wire as it emerges from the tip of the dilator, which can happen when you try to force the dilator over the wire. A kinked wire can tear the vein. To prevent this, I gently oscillate the wire back and forth to ensure it continues to glide smoothly as I advance the dilator.
As mentioned, it's critical to apply counter traction to the skin with the non-dominant hand. Make short corkscrewing motions to advance the dilator cleanly through the tissues. It helps to hold the dilator halfway along its length rather than at the hub. At no point let the tissues buckle or the dilator bend, which will kink the guide wire as mentioned earlier. Advance the dilator to the same depth as the needle to ensure it dilates the passage all the way to the vein. A change in resistance usually signals this. Note that I did not cut the skin in this elderly patient, as it was thin enough to just dilate. By not cutting, we reduce the risk of excessive bleeding at the insertion site where it has been removed. Unlike the internal jugular vein, there's little risk of it entering the right atrium or the ventricle with this approach. Now, another finesse tip is to withdraw the wire into the holder for neatness, in case you need it again.
As I advance the dilator.
Struggle with. So we'll start with a quick tip: overdilation at oozes central lines. If you've done many central lines, you may have run into where it just seems like after you put it in, that it just wants to bleed around your central line. The nurses are complaining because they always have to change their dressings, or just nothing sticks. It's just always just slowly oozing around that line. That's commonly caused by overdilation or sinking that dilator too deep. The dilator is just for the skin and soft tissue, and it is wider than the catheter. So if you hub that dilator, all you're doing is punching a big hole in the vessel that you won't be able to plug with a catheter, and it's going to bleed. And some of these dilators, especially for like an HD length trialysis line, something like that, these dilators are dangerously long. You definitely do not want to hub a trialysis line dilator. So you really want to just go in far enough that the widest part of the dilator has separated the skin and really dilated that part. You may feel that there's a little bit of resistance, but as you get to that soft tissue, that it kind of becomes just a touch easier and then it goes more smoothly. Really, you shouldn't have to dilate past that. You don't even have to dilate into the vessel. You definitely don't want to get the dilator all the way into the vessel. So we want to dilate along the trajectory of our original needle. Trajectory. We've made our skin neck, and now we're going to advance the dilator. You want to hold the dilator as you advance about a centimeter or so away from the skin, so you're feeding it in a little bit at a time. You don't want to hold it towards the opposite end, because as you're trying to advance, you can actually bend your dilator that way. I'm going to be holding close to the skin. And then we just want to advance it down. It should go fairly smoothly, maybe a little bit of resistance, but it should go smoothly. And again, just to remind you, the dilator itself is going to be usually at least 1 French larger than the catheter. So if you get the main width of the body of the dilator in the vessel, that hole is going to be bigger than the catheter, and it's just going to ooze everywhere, especially if the patient is coagulopathic. So at most, we're going to get the tip of that dilator in the vessel, and you really don't need to go that far. If you err a little bit on underdilating and have to dilate twice until you get a feel for it, that's okay. But you'll find that times where you have patients, with big lines, like uremic patients with uremic coagulopathy, if you can dilate those well, even though you're putting this fairly large dialysis line in this patient, it won't ooze around there because you'll have a nice seal. So let's talk about kinking the wire. If you haven't kinked a wire, then you probably haven't done that many central lines yet. But this is something that comes up not infrequently. And so it also can be a little bit frustrating because you'll say, oh, if there's resistance, you shouldn't advance anymore. But then maybe your staff comes in and pushes a little bit harder, then it goes smooth. And the next time you try it, you have some resistance, you push harder and you kink the wire. So why does that happen? So kinking of the wire occurs when you try to dilate on a trajectory that's not the same as the original needle pass. So we look here, my original needle is about 45, but now I'm dilating at a shallower angle. And that's going to cause that kink in that wire. So how do you know if you just need to push harder when you're having a little resistance, or if you're going in the wrong trajectory? So one of the really useful things you can do is kind of floss the wire back and forth, which we'll show here, by moving that wire in and out of the dilator. That will tell you if you're on the right trajectory. So let's say you're trying to advance a dilator and you meet some resistance. If that wire goes in and out easily, even with that resistance, then if appropriate, you can maybe try just pushing just a touch harder to see if you can just get the width of the dilator through, and you just need to go a little bit more, or potentially making a slightly bigger skin nick. However, if you're meeting some resistance and then you try to move that wire in and out and it feels stuck or caught, don't push any harder, stop, and then bring your dilator, release pressure with the dilator, and then try to bring the angle usually up, because you probably are dilating too shallowly compared to that original needle pass. But long story short, if the wire goes in and out easily, then it's okay to push a little bit harder or potentially make a bigger skin nick. If the wire's caught, caution, stop, release pressure on that dilator, and try to make that angle closer to the original needle pass. So last little quick tip here is that if you're finding that kinking the wire is something that happens not infrequently with you, one thing you might try is holding the dilator as you're advancing, kind of like you're holding a pencil, and just feeding it forward with your thumb and your index finger. By holding it like a pencil, this is going to just naturally cause that dilator angle to be a little bit more steep and really more closely approximate the original needle angle. I think you'll find you'll have a lot fewer instances where you're having problems kinking the wire. All right, that's what I have. Thank you very much, and I hope this was helpful.
Identifying the clavicle. Visualize a line at a right angle to the body's midline and align the probe with it. Tilt cranially until the subclavian vein and artery come into view, here highlighted in blue and red respectively. Note that it's not always possible to achieve a view where both vessels are visible at the same time, but it's vital to identify both in order to avoid an accidental arterial puncture. The artery usually pulsates and is located deeper, more cranially, while the vein is shallower and expands and contracts with the respiratory cycle, though note that it might actually pulsate due to the proximity to the artery. Prep a wide area, place the drapes and make sure to leave some space on the neck above the clavicle. Position the probe as far medially as possible, where the vessel is less prone to collapse and the diameter is larger. This is especially important in the hypovolemic patient. Inject the local anesthetic superficially a few centimeters from the probe. Cover the point of cannulation and where the sutures will go. Then inject towards the vein, but avoid puncturing it. Use the empty 2 cc syringe as an improvised handle and place the index finger along the cannula to facilitate lateral displacement. Advance the cannula towards the vein in a continuous motion, but proceed only if you see the needle tip. Aspiration of dark non-pulsatile blood indicates that we've successfully punctured the vein.
As always, I prepare my table with the instruments ready in sequential order. The anatomy should be clearly defined by palpating the sternal notch and identifying the angle of the clavicle. The location of insertion is approximately 2 to 3 centimeters inferior to the angle of the clavicle. I infiltrate the skin widely in a fan shape. I then insert the needle in the direction I plan to approach the subclavian vein. The needle stays at the level of the clavicle, and I inject the lidocaine into the periosteum of the clavicle. The introducer needle is positioned with its bevel up and inserted in a controlled fashion through the skin. I then drop my hand so that the needle and syringe are parallel to the patient. I advance the needle to touch its tip to the clavicle, allowing me to have a good understanding of exactly where my needle tip is located, while still safely at the superficial level of the clavicle. At this point, I pull the needle back slightly. I adjust the direction of the needle to aim at the sternal notch. Then, using my non-dominant thumb, I depress the tissue, causing the needle to be directed deeper. I advance straight forward underneath the clavicle while pulling back on the syringe. Once the subclavian vein is accessed, I turn the needle 90 degrees from its original upright position to a position where the bevel is oriented inferiorly. Dark blood should be easily withdrawn. I lock the needle into position with my non-dominant hand and remove the syringe. I check for any evidence of pulsatile bright red blood. If this is seen, you must assume that the artery has been accessed and the needle should be removed with pressure held for 5 to 10 minutes. Once the subclavian vein is successfully accessed, the guide wire should pass through the needle without resistance. Once the guide wire is in position, the needle is removed and a small skin incision is created along the guide wire with an 11-blade scalpel. At this point, the dilator is placed over the guide wire and advanced through the soft tissues. The dilator is removed and the central line should be easily passed over the guide wire completely to its hub into the subclavian vein. The guide wire is removed and the catheter is positioned at approximately 14 centimeters for a right-sided approach and 15 to 16 centimeters for a left-sided approach in the average size adult. At this point, the 3 ports should be easy to withdraw dark blood and flush easily with sterile injectable saline.
The key to avoiding pneumothorax is to never point the needle downwards. And this is the main pitfall with many of the techniques described elsewhere, which describe things like walking down off the clavicle. Now, if you scan the area with ultrasound, you will see that the pleura is approximately half a centimeter deeper than the axillary and subclavian vein. This is a very small margin if you angle your needle downwards, but it is more than enough to be safe if you do not. So the needle must be kept horizontal at all times, yet you must be able to get it under the clavicle. Your way to achieve this is by starting sufficiently far away from the clavicle, a thumb width away as described, inserting to first touch the clavicle and to determine its depth below the skin. Then we depress both syringe and needle as a single unit below the depth of the clavicle and advance it forward into the vein. This is illustrated here. The needle is inserted, the clavicle is touched to ascertain its depth, and then pressing down with the thumb on the needle tip and shaft and with the hand on the syringe, the entire unit is advanced parallel under the clavicle. Note that if you remain too close to the clavicle and feel yourself scraping along the underside of it, you may end up passing above the vein and missing it. It's important to be sufficiently deep under the clavicle.
Sure to have a comfortable working position with the ultrasound machine within your line of sight. Perform a pre-procedural scan and begin by identifying the clavicle and imagine the midline of the body. The probe should be placed at a 90-degree angle to this line rather than parallel to the clavicle. Now tilt the transducer in a cranial direction. At this location, you should see two vessels, a vein and an artery. The pulsating artery will usually be located deeper and more cranially, but in close proximity to the vein, which can be further identified by its propensity to collapse during the respiratory cycle or expand when the patient performs a Valsalva maneuver or is placed in the Trendelenburg position with lowered head and raised lower extremities. You need to be absolutely positive that you've identified both the artery and the vein. If this proves difficult, try a bit more lateral. Color Doppler may be useful, but is generally not required. If the vein is very small or located deep within the tissue, it might be a good idea to consider another location for central venous access. Prep the area. Once again, identify the artery and the vein and move the probe medially to the point where the vein dives in under the clavicle, which you see as a shadow to the right in the ultrasound picture. Start injecting local anesthetic a few centimeters lateral to the edge of the probe. Subcutaneous injection anesthetizes the area where the suture goes that holds the catheter in place. Next, inject along the planned path towards the vein and try to keep the needle in plane in order to visualize it and stop just before you puncture the vessel. There's no need to aspirate as you go along, as the volume of local anesthetic is too small to be toxic, even if injected intravasally. Now keep the probe as still as possible so you don't lose the view of the vein and the path that you've now anesthetized. Puncture the skin just lateral to the probe. Note how we've firmly lodged an empty 2 milliliter syringe in the cannula. With a firm grip around the syringe which acts as an improvised handle and an index finger guiding the cannula, it's much easier to achieve a perfect in-plane view. And remember that it's unsafe to advance the needle unless you can see the entire length of it. Now this is the point where we see that we puncture the vein, which we confirm by aspiration of dark venous blood.
Different. So that is the challenge of vascular access, and to do it at the highest possible level. More on this later. So I expect many of you have done ultrasound guided access, and I think it's important to recognize that many of you, I expect, will have done it in this approach where you have a nice image of the carotid and the IJ here, and you can see tissue wiggling, but you see either no evidence of needle tip in this case, or often what you might mistake for the tip that is not actually the tip. And that comes back to the creep technique, which we'll talk about in a little bit. So I would argue that this is not a satisfactory approach to vascular access, and that if this were my loved one, I would like you to know exactly where the piece of metal you are using to pierce the flesh and blood vessels is located, rather than simply relying on the trajectory that you can infer from this ultrasound guided image. And this is further echoed here, as you can see the operator in this case is desperately trying to, it seems, to go through the back wall of the IJ into the carotid. And for all we know, this part that we're seeing here with the needle, we don't know which part of the needle that is. For all we know, the carotid could already be perforated in this exact. A little side note on artifacts, in particular the ring down artifact, which is a vertical hyperechoic mark that you can see often that comes from tissue or fluid vibrating in the lumen of the needle during cannulation. It can pose a hazard, as you may mistake it for the needle when it's actually an artifact. So just be on the lookout for the ring down artifact. that you could come across in your hands-on practice. Now we're moving on finally to this creep technique, which I've alluded to. Now, the creep technique is one that involves the progressive advancement of your ultrasound probe just beyond the needle tip, and then moving it back to just intersect with the needle tip. And this way, you'll, as I'll show you in a minute in a live video, be able to be certain always what the leading point of your needle is, and therefore never go in too far, and always be certain exactly where you are in space, which is uncommonly the case. Because if you look at the schematic, if you just put the probe on here with a needle tunneled under the flesh, you will immediately see this hyperechoic spot on the ultrasound screen. You say, oh, well, there's my needle tip. That's the natural assumption everybody makes. You say, oh, there it is. And you start advancing your needle with assuming that you've got another, say inch or whatever of depth to advance. Meanwhile, your needle's actually already, if this is black thing as the vessel, already through the back wall. And this is the hazard that people get into. So the way to get around this is to advance your probe, advance beyond the tip of the needle, and such that this is your ultrasound screen display, and then move it back to be confident that this is then the distalmost portion of the tip. And that way you can then advance your probe again a little bit beyond, and then advance your needle into the field of view of this one, and you slowly do kind of a back and forth approach, which I'll show you again on an ultrasound image. Because otherwise you end up in this case, we assume this is the tip of the needle. We assume that hyperechoic lesion, or spot rather, on the at the IJ there is the needle, but we have no way of confirming that unless the operator has done what I've just described, in which case I don't expect they'd be frantically pushing on the IJ the way they are. So we'll go through this again here. So you can see that as you image through here, this is the shaft, this is the shaft, this is the tip, and this is the BTT point, or the beyond the tip point. And the only way you can know that, of course, is to actually go beyond the tip such that you no longer see any metal or any hyperechoic spot on the screen. And then the first hyperechoic spot you see as you come back towards your needle will then be the tip. The next, I have a real-time example here that I'll repeat for you a few times. And what you'll see here progressively is the operator seeing the tip, advancing the probe, advancing the needle, advancing the probe, advancing the needle, and advancing the needle again just into the vessel. So this kind of song and dance maneuver where the operator is clear at all points exactly what the leading edge of their needle is doing, and so is clear they will never, ever, ever go anywhere they don't want to go, which is an incredible, incredible gift to your patients and a fun way to do the skill, because you'll find you can get a needle almost into any space if you use this technique called the creep technique, or call it what you will. Needle, and we know it's the tip each time because each time the operator moves the ultrasound beam beyond the hyperechoic spot just a little bit.
That is the carotid artery over here. That is the skin and subcutaneous tissue underneath. This is the part of one of the superficial cervical fascia, and that is the internal jugular vein, which we can see over here. Now, extremely important rule is when you apply ultrasound probe on the lateral side of the neck, trying to identify the internal jugular vein, you must apply extremely light pressure. This is easier said than done. Too much pressure on the ultrasound probe can completely obliterate the lumen of the internal jugular vein, and it can be counterproductive. However, you should try to see how much pressure you can apply and what the pressure of the ultrasound transducer does to the internal jugular vein. Because once you learn how much it is important to avoid applying too much pressure, whether by ultrasound transducer or by palpation, if you do this procedure without ultrasound, you will actually understand how it is crucial to avoid pressure in order to allow the internal jugular vein to remain open. As we can see, typical ultrasound setup is about 3 centimeter depth, and it really does not matter all that much where you place your focus zone for this particular procedure. However, I will say that you must always increase the gain. So that is a very important tip. Every time you do a vascular access, you must increase the gain. And that is because we're not trying to decipher any of these anatomy or musculoskeletal anatomy where the gain adjustment is very important to be balanced, but rather we're trying to accentuate the dark appearance of the blood vessels against the rest of the musculoskeletal or rest of the tissue, which is much brighter. Here's the ultrasound image. We can see the carotid artery. That's the internal jugular vein. And as the needle is approaching over here, we can see the needle is pushing on the anterior wall of the internal jugular vein. So that requires a little bit of repositioning. And that is the tip of the catheter. Okay, now let's see the catheter. So that's the catheter placement. You can see how much pressure on the vein can obliterate the vessel wall. So you really need to make sure you do not exercise too much pressure here. So that's the catheter, very nicely displayed inside the internal jugular vein, which is 100% confirmation of the proper catheter placement. That's the catheter now seen using an addle-plane approach, and again it's very nicely nested against the posterior wall of the internal jugular vein. Again, a very powerful and important confirmation of the catheter placement inside the internal jugular vein.
Struggle. This is something I see commonly. I call it joysticking, where you're holding the probe up off the patient. Don't do that. So there's no way you're going to get precise probe control holding a probe like this. You can see that my hand is far off the patient. I'm just kind of hovering in midair. You're not going to be able to move precisely. You're going to be putting way more pressure on the patient than you should be and obscuring your view. Proper probe control or probe position is holding the probe with your hand firmly anchored on the patient, your hand firmly anchored to the probe, and the probe kind of lightly on the patient. I tell my residents on the anesthesia side, if they're up overnight and don't have anything going on and kind of bored, they have an ultrasound. One good way to know that you have adequate probe control is if you can have a friend and you can put that probe on there and put a vein or an artery or something random on the middle of the screen. If you can pull your cell phone out of your pocket, look down at it, send a text, put it back in your pocket, and if you look back on the screen and the probe hasn't moved or the vessel hasn't moved, you're doing a good job. And that really, it sounds kind of silly, but that's really critical. I don't know how many times I've seen people when they get the vessel on the middle of the screen and they're about to numb the patient before they do a stick, they grab their lidocaine, they look down at their hands, they inject the skin, and they look back up at the screen, and all of a sudden the vessel is all the way off the side and they numb the wrong area. So really being able to have this probe control where the vessel doesn't move unless you want it to is absolutely critical. So again, hand firmly attached to the probe, hand resting on the patient, probe lightly resting on the patient. In an idealized world, you would have the probe kind of hovering or off the patient with a layer of gel in between the patient and their skin. This is not exactly realistic. You are going to have the probe on the patient a little bit, but it's definitely going to be, it should be a lot more similar to what's on the left than what's on the right here. You really don't want to be pushing down terribly hard, especially when you're trying to do venous access, and especially if they're hypovolemic, because you're quickly going to find that your target vessel is going to be a lot harder to stick, and it may just disappear completely. You can see here in this video, previously large vessel is now very, very collapsed when they're pushing down with the probe. And that's not uncommon at all. This is critical in hypovolemic patients. Not uncommonly, I will do a line in a patient or either peripheral IV or a central line where other people have struggled and the patient's very hypovolemic, and it's usually they have really small target vessels or they aren't finding anything for like a peripheral IV. And then when I try, I just gently rest the probe on the patient, and I have all of a sudden these big targets that other people could hit. It's just they never saw them or made the targets a lot harder to hit because they're pushing too hard. It's a really low-hanging fruit in terms of making things easier for yourself, especially in the hypovolemic or hypotensive patient. All right, so now talking about needle tip visualization. So this is absolutely critical in the short axis out of plane approach. The out of plane approach, you're really going to get a cross section of your needle tip, of your needle, I should say. So if you have the beam over the needle tip, you're going to see a dot. If you have the beam over the middle of the needle, you're going to see a dot. So the only way you know that you are at your needle tip is if you move the beam past the needle and the tip disappears, or the dot disappears. That means you're now past the needle, and then you come back. So as soon as you hit where you're getting the dot back on the screen, that means you're at your needle tip. So this is absolutely critical when you're doing an out-of-plane approach, is you're constantly going to be playing kind of a hide-and-seek game with a needle tip. You're going to be going just past it with your probe until it just disappears, and then advancing your needle so it comes back on the screen. Again, absolutely, absolutely critical. In the in-plane approach, where you have your needle visualized the whole time, you don't move your needle unless you can see it. In the out-of-plane approach, you don't move your needle tip. You don't move your needle unless you can't see it. But you should be advancing just into that beam so you always know where the needle tip is. Can everyone see my needle tip here? Here, I'll jiggle it. You can see that nice bright dot right in the middle of the vessel. Looks great, right? Well, we never actually saw it disappear. So let me go into long axis here and take a look. So that was not my needle tip. That was the middle of the needle. So you can see the needle tip is through and through the vessel. And this is actually how you can stick a carotid or dilate a carotid on an ultrasound guided approach, is if you never actually know where your needle tip is and you just jiggle the needle and you see something moving and assume that's your needle tip, that can get you in trouble really fast, especially in small vessels with close proximity of other structures. So if we actually go back to the short axis here, now I'm going to follow the needle tip down, or follow the needle down. I'm going to move the probe forward and forward and forward until that bright dot disappears. So that was my needle tip. That's how I would know that was my needle tip in the short axis view. By going past it until it disappears, then I bring the probe back, it reappears, and it's right there. So that's how I would have known that was a needle tip. All right, another really critical point has to do with what's called the angle of incidence or angle of incidence. And this has to do with the angle of the needle compared to the angle of the beam coming from the ultrasound. So if the needle is perpendicular to the ultrasound beam, your sound is going to go down, hit the needle, and come right back up, and you're going to have a very bright white needle tip as the vast majority of that sound energy is going to return to the ultrasound probe. However, as the needle increases in steepness and the angle of incidence decreases, then more of that sound energy is actually going to be reflected away from the probe, and your needle tip is going to become less visible. As you get to an extremely steep angle, then you may have the vast majority of that sound energy being reflected away. And so you might encounter this as if you have your needle entry point, like say right next to the probe. That's going to make you a very steep angle. This is, I think, a really critical thing to know, as I guess in a perfect world, you would try to stay with a very shallow angle and being perpendicular to that beam of sound. However, if you have a deep vessel that you're trying to access, you're never going to be able to reach it if you're always staying at a very, very shallow angle. And so by knowing your relative angle compared to that beam of the ultrasound beam, you can kind of calibrate what you're looking for on the screen in terms of, are you expecting a bright white needle tip because you've got a pretty close to 90-degree angle, or are you very, very steep, and then now you're not expecting to see a bright white needle tip. What you're looking for is just a shadow or maybe some subtle tissue displacement. So again, kind of to reiterate that, we have our 90-degree angle, we're going to have a bright white tip. As we increase in steepness, we're going to get progressively harder to see. So here's a video clip showing kind of an example of this. We have the ultrasound in the upper right corner. You never really see the needle, but you can see this person has gotten flash in their syringe. And you can see that they've entered the skin right next to the probe, so they're at a fairly steep angle. And again, really there's no evidence of the needle. Well, there's minimal evidence of the needle here up on the ultrasound image. Kind of some more, to kind of bring this point home a little bit more. This is actually the long axis view, but you can see that this needle is somewhat hard to see, and some clever people out there have tried to make devices and techniques to improve the visualization of this needle, but it really comes down to getting that angle of incidence or angle of incidence back to 90 degrees as best as possible. So if you've ever heard of like an echogenic needle or these easier to see needles on ultrasound, really all those do is they have fancy notches or steps kind of built into them that try to reapproximate that 90-degree angle as the needle itself is actually more at like 45 degree. Also, some of the fancier biopsy ultrasounds or something that my IR might use actually can do something called beam steering, used a phased array. But again, all that's doing is trying to reapproximate that 90 degrees to give you a bright white needle and easier to see. Just a really quick tip, kind of a quick commercial break here. I'm keeping track of your bevel. So if you put the needle on the syringe with the bevel facing up and the numbers of the syringe facing up, and that way, even if the needle is in the patient, the needle tip is in the patient, if you can see the numbers of your syringe, you know that the bevel is up. Another bonus tip here is that you really don't want to over tighten a needle on the syringe. So a little bit of foreshadowing here, but one of the common ways that people screw up a central line or aren't able to thread the wires once you've accessed the vessel and have flash is as you're trying to take off that syringe. If it's on there really, really tight, you can get a lot of movement as you're trying to force that syringe off, especially if it's a small vessel. So you really want to be very careful and just have it on barely tight when you put that needle on the syringe. So kind of putting it all together, let's go through kind of the process of doing a central line. When you first pick up the probe, you always want to do a sanity check to make sure that left is left. If the room is a little dark, it's hard to see that dot, or especially after you put on the probe cover, it's going to be really hard to tell which side the dot is on the probe. And I promise you, if you don't check this, you will have a number of times where you'll really struggle, and it'll take an embarrassingly long time to figure out that your probe is switched, and that left is right and right is left. So to this day, whenever I pick up a probe, I always touch one side to make sure that left is left. So the first thing we're going to do is coming back to, we really want the vessel to stay in the middle of the screen, so we're not chasing it with our needles. We do a pre-scan survey. This is also going to evaluate the vessel to make sure that it's patent, there's no clots, anything like that. So what we want to do is we want to run our probe up and down the vessel. And as we do that, we really want it to stay in the middle of the screen. You can see here that it's moved off to the side. So as we go, if we're not in line with that vessel, it's going to move closer. Well, the probe side is going to move closer to the vessel, and it's going to appear to go from side to side. So we want to be able to find an orientation of that probe that as we move it up and down, that vessel is really going to stay in the middle of the screen. You can kind of think of the vessel as a railroad track and your probe as a train. We really wanted to have it staying perfectly over that vessel so the vessel stays in the middle of the screen, and that way you're not chasing after it when you have a needle with your needle tip. This can actually be a little bit frustrating at first, especially if you don't kind of have that muscle memory of how to automatically adjust, but it's really something I wouldn't rush, and I would really make sure that I could do this easily every time I do this with a patient. I make sure I can, because I promise you it's not going to get easier once you have that needle in their neck. So a little trick, if you're having a hard time and things are just not clicking, and no matter what you do, it seems that the vessel is running off to the left or the right, one thing you can do is kind of in your head make an imaginary X, kind of closer to you where the vessel is in the middle of the screen, and then just move the probe up, and if it moves off to the side, that's okay. But just put the vessel in the middle of the screen down wherever you are, and then draw an imaginary line between the two, and that can kind of help orient you to make sure that you are on the right axis. So this is a really important line here, the line of the vessel. You really want to be kind of everything in line with this. Behind the patient's head here, I want to be standing with my shoulders square to the probe so that I'm not off to the left or right. I want to be really shoulders kind of, again, parallel to that probe. And my needle is going to be entering the patient kind of directly in the middle of the probe. So again, I'm going to be moving along this line, and then out towards the patient's feet I want to have, or off to the side I want to have the ultrasound screen so that I can just look up and down and I'm not turning my head to the left or the right, just everything along this plane here. So here's me running, doing a vessel survey. You can see on the left that my hand is moving fairly slow, but on the screen it seems to be moving pretty quickly. So this is about as quick as you want to move, and when you actually have a needle in the patient, you're going to be moving even slower than this. You can also see that my hand is braced on the patient with my pinky finger kind of resting, and I'm really moving the probe up and down just with my thumb, index, and middle fingers there. I want to be very, very well braced. Again, I should be able to look down, I should be able to pull a phone out of my pocket, I should be able to look all over, and when I look back at the screen, the vessel should still be in the middle of the screen. So now we're going to put it all together. We have done our pre-vessel survey, and now we're actually going to try to access the vessel. So our focus here is really going to be picking a needle entry site, and again, needle tip visualization is absolutely critical. So here we are. We're going to do our pre-scan. We can see that our vessel stays in the middle of the screen on our ultrasound. Then now we're going to pick our entry site. So some people might try to enter the skin right next to the probe. I recommend not doing that routinely, especially with a vessel that's fairly shallow, like 2 or 3 centimeters or less. But really more, I like to pick an entry site that is about the same distance away from the probe as it is deep, because that's going to give me a needle trajectory of about 45 degrees, which will give me a reasonable visualization of the needle tip, while also allowing me to get deep enough to access the vessel. If you're going after a vessel that's very deep, like potentially like a subclavian or something, you may not be able to go back 5, 6 centimeters, but by staying back at least a couple centimeters or a little bit farther if you can, it will increase the needle tip visibility. And if you're unable to do that and you have to enter the skin closer to where the probe is, then just realize that your needle tip is not going to be nearly as easy to see. In terms of entering the skin, left, right, or center of that the middle of the probe, I would really recommend entering kind of dead center of the probe. So your goal is to be right over the target vessel, the straight down trajectory. Sometimes, especially newer folks, they see the artery over there on the left, and they're really worried about sticking that, so they stick the needle in the skin on the opposite side of the artery. I would really strongly recommend against doing that, because if you look at the trajectory you need to take to get to the vein, you aim right at the artery. I would highly recommend that you try to aim for the center of the vein and go straight down. However, if you're going to cheat one side or the other, I would actually say cheat artery side, because that's going to give you a trajectory away from the artery. Again, I would say aim towards the middle and go straight down. But whatever you do, don't cheat on the opposite side of the artery, because you'll end up aimed right at it. All right, so we've done our pre-vessel scan. We've got our target entry site. Now we get our needle through the skin. This can be a little challenging, especially with floppy skin, and we want to hold tension. So if you have your probe hand resting on the patient, you can actually use like the hypothenar eminence of your hand to pull traction on the skin while it's also holding the probe, which is another bonus of having your hand resting on the patient with the probe. But okay, so we've gotten through the skin with a nice 45-degree angle. But again, that should give us reasonable visualization of the needle. But if we wanted to see the needle tip very well, we would be more at a 90-degree angle. So what I usually do here is I drop the angle of my needle, which to make that 90 degrees or close to, and then I'm going to bring my probe back to find that needle tip. And I should have a fairly bright white needle tip to find here. And that's going to give me that nice angle of incidence to where I can see a good visualization. So now I know where I am and I know where I'm starting. So I'm going to bring with the needle tip in view, I'm going to bring my needle back up to the angle I'm going to be using to access the vessel, and I'm going to be watching that on the screen at the same time. So now I know exactly what my needle tip looks like, how bright it is or how not bright it is, but at least I know the signature of what that's going to look like. If you do this technique, especially early on, I'd recommend really making sure, even look down at your hands after you do it, that you get the needle angle back up again. So if you start low, like I suggested here, and you aren't paying attention, sometimes you can think that you increase the angle of the needle back up, and you never really do, and then you stay a lot more shallow than you meant to and run out of needle. So the first few times, if you do this technique, you get through the skin, drop your angle, find your needle tip, but really pay attention when you bring the angle back up. Make sure that you're getting back up to like a 45, because that's one of the areas I have seen people trying this technique struggle a little bit. But if you just pay attention and make sure your angle gets back up, you'll be fine. Okay, so now we know exactly where our needle tip is. We know our starting point. So now what we're going to do is kind of play the hide and seek that we talked about earlier. So I'm going to bring my probe forward. I've lost the probe or the needle tip, and I'm going to walk the needle tip down. So again, I'm going to just lose the needle tip, so it disappears, and I'm going to advance the needle back into the view there. So again, a lot of the needle visualization isn't so much that you're getting a bright white needle tip. You can still fairly easily find a needle tip that is subtle or just a little bit of a shadow. If you know the exact square centimeter on the screen you're looking at, you're not scanning up and down the neck frantically looking for this needle tip. And so it's really critical kind of once you started this process where you're marching down to the vessel that the probe does not leave the patient. You don't break contact with the skin. You don't put it down, because if you lose your needle tip, and once you're kind of at this point, it's almost sometimes, especially early on, better to kind of go back to the start and retry again. Because again, it's easy to follow a needle if you know exactly where you're looking. It's hard to start from scratch to find a needle in the middle of the neck somewhere. Okay, so now we've gotten almost to the vessel. So it's kind of a next phase is to actually access the vessel itself. Once you get the needle at the vessel, you'll see tenting. Before you actually enter the vessel, you will see tenting of the vessel itself. You may actually see the needle tip right at the vessel, but not infrequently. You'll actually, the needle tip will kind of disappear at this point. And so really I'll use the tenting itself as my target of where the needle tip is. So kind of the same idea of the hide and seek, the same thing here. I will move the probe until it disappears, come back, and just keep looking for that tenting. And that's how I know where my needle tip is, even if I can't see it at this point. So now I'm ready to actually access the vessel. So I'm going to advance my needle. It may be, at this point, especially early on, it can be a little bit of a struggle, because if you're hesitant or a little bit slow, you're trying to slowly advance, commonly you can just collapse the vein and never actually enter it. So really you want to make sure that you're steep enough here. And also, sometimes you need to do just a little bit, I don't want to say the word aggressive, but you got to kind of commit to getting through that vessel. So really, make a half a centimeter, deliberate advance to try to get through that vessel and kind of pop through. Again, we're talking like half a centimeter or so. You don't want to go through and through, but you really have to be kind of decisive at this point. Otherwise, you can just kind of slide across the top or just collapse the vessel and not actually enter. And it can take a couple of these to get comfortable with that, but it's not as bad as you think, and you'll quickly get a feel for it. But all right, so we're ready to actually enter the vessel. So I can't really see my needle tip, but I do see where I'm tenting. So now I'm going to advance my needle. And what I'm looking for is I'm going to see that tenting go away. And then commonly you'll actually see kind of the inverse where it kind of peaks up a little bit. Maybe not, but definitely the tenting will go away. And I will also expect that I have flash in my syringe at this point. So my next step is many people will try to immediately thread the wire right here because they've got good flash. But I would suggest not quite doing that just yet. And we'll talk about that in just a minute. At this point, though, I will follow my needle tip all the way down, so I know exactly where I am. So just a really quick aside here. You notice that in these clips I've been showing that I've been doing a slide technique where the probe remains the same angle as the skin, and then I'm just sliding it down the neck or wherever I am. And I think that's a good approach to do because it does give you a reasonable angle of incidence or incidence, so that you should have hopefully an easier time seeing your needle tip. Again, it's not going to be as bright as if your needle was flat. But you may see some folks, instead of doing a slide approach, they'll actually do more of a fan. And I would actually, if you're having a hard time finding your needle tip, I recommend this not be your primary approach. If you do this already and it works for you, it works for you. But you can see that as I fan the probe down so that my beam goes forward and I can follow the needle tip, you can see that the angle of incidence is really going to steepen up, and this will progressively make your needle tip harder and harder to find. It's still totally doable, and as your skills improve and you're able to have that precise probe control, it may not be an issue, and there may be times when this is what you have to do, especially if you're really close to the clavicle. But I wouldn't recommend that be your default, especially early on, or if you have a hard time with finding your needle tip. Conversely, you can actually cheat the probe forward a little bit to really try to get closer to that nice 90 degrees. And so I will use this technique sometimes if I say I have lost my needle tip and I'm really having a hard time finding it. By cheating my hand forward and tilting the probe away from me, I'm going to get that better angle, and then I can use that hide and seek technique to kind of, again, try to find. You can use this technique to do this all the way to the vessel, which is totally valid. But one problem you may notice, that especially if you're up doing an IJ, is that the clavicle kind of impedes your ability to bring the probe far enough down and you aren't able to chase it. So you may have to actually go back up straight. But if it works for you, it works for you. At the very least, I think it's a good trick to have in your back pocket if you do lose your needle tip and you're trying to find it again. Here's just an image of somebody. You can see that they have cheated that probe away from them to try to re-approximate that 90-degree angle. Again, pay no attention to how they're holding the probe. Don't do that. But you can see the angle there. Okay, so now here's a clip of me, and we're going to go from kind of skin to just about where we're ready to poke the vessel. So you can see it's a little bit hard to see, but my needle tip is entering the skin of this dummy here about the same distance as the top of the vessel. I'm going to get through the skin, keep my angle very shallow, And I'm going to bring my probe back. Now you can see that bright white needle tip there. So now I know where I'm starting from. So now I'm going to bring the angle of my needle up. So I'm getting ready so I can have a nice trajectory to get it into that vessel. So now the angle of my needle is up. So I'm going to get ready to enter the vessel. I lose my tip. Now I advance my needle into view. You can see that the vessel is tenting. And now it's rebounded, and I'm into the needle. I'm into the vessel. All right. So now we've got our flash. So what's our next?
Play with your depth and gain. So here's a great example of Valsalva maneuvers power to change the caliber of a previously virtualized IJ into quite a large and plump IJ. The
most common issue is failure to locate the vein. If the patient is very hypovolemic with low venous filling pressure, blood may not be aspirated despite puncture during advancement. So if there's been no positive aspiration and the needle has been inserted to the hub, withdraw it slowly while maintaining constant gentle traction on the plunger of the syringe. As the needle tip re-enters the vein, the withdrawing motion usually pulls the vein walls apart and the vein open, and aspiration of blood should occur. Increase head-down positioning as well to maximize vein filling to the fullest extent possible. Ensure that you are not scraping along the clavicle, which may mean that you are passing between the clavicle and the vein. Finally, you may attempt redirection in first a slightly superior direction, aiming for a point along the clavicle, more lateral to the sternal notch, and then in a slightly inferior direction. Arterial puncture is very rare in my experience. It has never yet happened to me. But if these steps still do not result in success, I would move to an alternative technique.
So beautiful. So let's talk about long axis approach. Everyone loves the long axis approach. I mean, look how pretty that is, watching that needle go into the phantom vessel there. You can see the needle whole way. None of this creep technique. It looks so awesome. It's great. But the question, of course, I have for you is, where's the other vessel? Where's the carotid that we're trying to avoid? I mean, remember, the very point, or one of the major points of ultrasound guidance, is to avoid the carotid. By using the long axis, you discard this information and you effectively, I think, reintroduce some risk, particularly because this depiction of the long axis as shown here is not often real life. Lining up the needle in long axis perfectly with the ultrasound beam is much like lining up two credit cards or two thin pieces of paper to sit on top of each other. It's actually quite difficult to do, and I would suggest this is an expert or advanced user approach, and would suggest that this is much more what real life looks like. You have a faint, more faint image of the needle. You have the vessel in long axis. We don't know where the carotid is, and at this point we're not sure if we're in, because we might be a little bit out of plane. We've actually, we might be in two different planes here, even though we're still in the long axis. So it's a bit more challenging. I would suggest stay away from this, aside from in phantoms or in simulated scenarios, until you're really quite comfortable. There is an alternative approach called the oblique technique, which kind of uses both the long and the short axis approach together with a probe on a 45-degree angle. But again, I would suggest that's reserved for people who have a fair bit more experience in using ultrasound guidance. And once you master the creep technique, you'll never have want really for any other techniques, in my opinion.
Last night, well, just go on the left.
Left groins are usually a pretty safe place to go.
If I'm going on the left groin,
Yep.
I'm a righty,
Yep.
and if I'm on the left side, it's kind of gymnastics.
Yeah.
Should I just lean over?
That's exactly right. So if you're a right-handed operator, you always want to be on the patient's right side, and it gives you access to both groins very easily. I could access here, or I could just reach over with my ultrasound probe and access there. So that's exactly right.
All right. Thank you, Scotty.
All right, thank you all.
In my opinion. Now, the femoral approach is easily done. The inguinal crease is the place to put the probe. Again, the index mark rules with the probe and the machine apply, line them up so they sort of are aligned, pointing in the same direction. And the vessels and the anatomy are as you remember them from the blind approach. The vein, as seen here medial to the artery, which looks like it's bifurcated here, is easily struck. The interesting thing is the saphenous vein up there is commonly hit during a blind approach, and explains many of the times that you're unable to thread your guide wire or to get your cordis in, it's because you may be in a branching vein of the femoral.
Here's a tough but unfortunately common situation to deal with. Starting a femoral central line on a patient that's pulseless or so hypotensive that you can't feel femoral pulse. It takes away one of your common landmarks for a femoral central line, but here's how I deal with it. So no matter how big or small your patient's lower body area is, the femoral vein's always going to be in the same orientation with respect to the bony landmarks of the pelvis. So let's use that to our advantage. Now, as you guys know, the inguinal ligament runs from the pubic tubercle to the anterior superior iliac spine laterally. Now, if you take the distance upon which the inguinal ligament lies and divide that distance into thirds, the femoral vein runs under the inguinal ligament about a third of the distance of the ligament away from the lateral side of the pubic tubercle. So here's a quick way to reproduce that measurement to put in a central line. Take your hand and arrange it in almost an L shape like this, and take the tip of your index finger and place it on the patient's anterior superior iliac spine. Then take the thumb of the same hand and place it on the lateral side of the pubic tubercle. The line from the tip of your thumb to the tip of your index finger should be running exactly along the inguinal ligament. If you drew a line from your thumb crease in your hand to the inguinal ligament, that measurement is almost exactly 1/3 the distance of the inguinal ligament. Now all you have to do is lie the syringe in the thumb crease of your hand, enter the skin with the tip of your needle right where those two lines intersect. Directly underneath that intersection lies the femoral vein.
Ultrasound findings. You see a spot on the screen, it looks like it's in a vessel, and believing that even though you have pulsatile blood or a gush of air preceding that or after that, that you're in the vessel. So please, as best as you can, try to be very humble in your findings and recognize this is a new skill for you, taking in multiple data points while performing a complex set of interactions with needles and Seldinger technique and sedated or critically ill patients. So just, a little bit of humility up front will go a long way. We often see a spike in complications for early users of ultrasound guided access because they start ignoring their basic senses regarding where their needle might be or where they are in the neck. The other things to be mindful of are the clot in the lumens, or if the vein is too small, or other pitfalls that I've mentioned. And here we'll look at a couple of those. So here you can see a clot in a previously cannulated IJ in an ICU patient. You can see some wisps of clot and complexity there. So the right answer is always to pick another side, though we don't know the morbidity of cannulating at these sites. We expect it doesn't bring good favor to the patients. And this is an interesting case from the ED from a few years ago. You can see after first attempt, there's a carotid there, and the IJ is somewhere up here, we believe. I was asked to have a second look at this, and what certainly I was able to deduce was that after an unsuccessful poke, inability to pass the guide wire, there was a massive hematoma here now along the back wall of this IJ that's compressing it and making it very difficult to gain access. And many of you will see this as you sweep up and down the neck, and you'll recognize this valve structure right at the base of the IJ as it enters into the subclavian. And if you're seeing that, that's great. It's just a valve. You don't need to worry it's a clot, but also be mindful it means your probe's way too low on the neck typically, and you should move it back up to about the height of the cricoid cartilage, where you'd probably like to cannulate under most circumstances. Confirming your guide wire, I've mentioned already. You can also confirm the actual catheter itself, perhaps obviating the need for radiography after after placement. And you can see the cordis here entering the IJ with the carotid and long axis. It's always easier to confirm the presence of the guide wire or the cordis itself using a long axis approach. When there's extreme turbulence in the vein, as in the case of, say, SVC syndrome or other unusual diagnoses, probably best not to stick thrombogenic catheters in the midst of a clot in process, as you can see here with the spontaneous contrast in the IJ. And perhaps the ultimate technical difficulty or complexity is this patient receiving CPR with their IJ lying directly over top of their carotid. This is an immediate invitation to perhaps choose another site or to lower your expectations in the context of cardiac arrest. I would favor the choosing another site, either a femoral approach for good reason or a subclavian approach. Please remember to maintain the machine, especially when it comes to invasive procedures, and especially with the mortality rates that we know that central venous catheter infections can produce. So please, please, please clean the machines for the sake of your colleagues and your patients. So in summary, you're going to use ultrasound guidance from now on. We're sure of this. You're going to use the short axis, I hope, and the creep technique in all its glory. It's a fabulous technique. Needle tip control from that technique will allow you to cannulate veins, arteries, peripheral veins, even entertain regional anesthesia techniques, tapping of joints. The tip visualization, as long as you master that, you can become an excellent needle wielding physician or provider. And I strongly emphasize confirming your guide wire before cannulating anything, and beware of your overconfidence and the overconfidence of others.
About labs. To begin with, follow your local protocol. Our local guidelines state that with an INR above 1.8 or a platelet count below 50, you may consider giving procoagulants or transfusions. However, our guidelines also state that an experienced operator can place a line regardless of labs, if he or she does a pre-scan and comes to the conclusion that the procedure may be carried out safely. There will sometimes be a discussion regarding choice of cannulation site if the patient is coagulopathic. In my opinion, coagulopathy is not a concern if you're a skilled central line inserter, meaning that you're able to clearly differentiate the artery from the vein and master the in-plane technique. It helps if the pre-scan shows a large vein. I prefer the subclave approach because of the longer distance from the vein to the skin, thereby preventing backbleeding from the vein to the dressing. You may of course add epinephrine to your local anesthetic to avoid skin bleeding. Should oozing from the sutures or the insertion site occur, just apply pressure to the puncture site and give transfusions or procoagulants that is needed according to the labs. Local procoagulants like StatSeal may also be used. I'm well aware that an arterial puncture in a non-compressible site in a coagulopathic patient would be very unfortunate. Here's my personal take. A central line is an invasive procedure and I always make sure that I agree with the indication. But if the patient needs a central line, I would place it regardless of labs. I believe I'm a very experienced central line operator. I always do a pre-scan, and if the patient is coagulopathic, I choose the best location. If I don't have labs, I don't wait for them. In particular, if the central line indication is inability to place peripheral lines, I wouldn't want to waste time trying to draw peripheral blood. I would place the line without labs, as they don't change my decision to cannulate. But once again, this is my approach. Know your limitations, follow your local guidelines, and ask for help if needed. Grab the protective cover as shown, catch the probe, and let the assistant pull the cover. Make sure to remove all creases from the probe head and place the elastic band without rubbing away the gel. Fold rather than pull the cover. We like to have the ultrasound cable placed on a custom hanger. It makes the whole procedure a lot easier and you can leave the probe hanging while not in use. Avoid excessive amounts of ultrasound gel. Simply begin with a little dollop in the medial edge of the area, rather than putting it all over the place or on the probe itself. This is extra important if you use the microconvex probe, as too much gel makes the probe slippery against the skin. And always avoid getting gel where you'll puncture the skin. Wipe with sterile gauze if you need it. It sounds basic, and it is basic. Just tap on the side of the probe to determine which side of the ultrasound screen it corresponds to. Always drape the patient to allow for both subclave and IJ access. To shift to the oblique approach, it's just a matter of moving the probe a few centimeters cranially and rotating it 45 degrees. Stay put by the side of the bed. There's no need to move up to the head of the bed. You can just as easily cannulate the IJ standing by the side of the bed if you use the oblique approach. It's a humanitarian obligation to make every procedure as painless as possible. Local anesthesia is good for the patient, but it's also good for you. Cannulation is easier if the patient doesn't scream, breathe heavily, or move around. Make sure you do the local anesthesia part as an ultrasound guided procedure. Use a thin standard needle for the subclave approach. Get hold of the extra long thin needle pictured here. Take care to anesthetize the point of cannulation, the suture site, and then inject towards the vein. Do it in plane and use this as a test run for the cannulation. Note though that the thin needle can sometimes be more difficult to visualize and it's harder to do the lateral displacement. If you can't visualize the needle perfectly, that's okay. Don't push it too much, just inject superficially and the local anesthetic will spread along the fascial planes. There's no need to aspirate, as the small amounts of local anesthetic, averaging about 5 milliliters in most cases, is never as toxic in an average-sized adult patient. You may need to adjust your puncture site based on the patient's external anatomy. In this patient, the shoulder is in the way for optimal needling. See how I make a slight rotation where I find a good puncture site without losing sight of the vein. Avoid multiple skin punctures. Use the same site to avoid oozing. Rather than doing a new skin puncture, just do the superficial lateral displacement, which is easy in most patients. Don't aspirate as you advance the needle. That will make it harder to hold the cannula for lateral displacement maneuvers. It's obvious from the ultrasound image when the needle has punctured the vessel. A slight give may be felt and you will often see the tip in the vein. This is when you should aspirate. Then remove the syringe and quickly cover the bore of the cannula to prevent bleeding and air embolism. Sometimes you're willing to wager your firstborn child that you're in the vein, but you get no backflash of blood when aspirating. It may be due to clotting in the cannula. Retract and flush the cannula, with air preferably. Keep the end of the guide wire in the plastic loop when you perform the SUBCLAVE procedure to confirm the guide wire tip position. This avoids contamination of the guide wire and enables manipulation of a dislocated guide wire. After having inserted the guide wire, always do an extra check to make sure that it is inserted in the vein before you dilate. If possible, verify the guide wire tip position close to the right pulmonary artery, as we mentioned in the supraclavicular fossa video. Use the number 11 blade before dilatation for anything larger than 7 French, unless the patient is an octogenarian with chronic steroid use and really soft skin. Make an incision that's just right in size. If it's too big, bleeding will occur and you may have caused an infectious complication. Dilatation is crucial when inserting any catheter with more than 2 lumen. Dilate the tract with intermittent guide wire movement to make sure it moves freely. Rotation of the dilator may be beneficial and very helpful. This avoids the frayed tip and the kinked guide wire that can arise if the cannulation has been made at a steep angle in a thicker vessel wall. When removing the dilator, place a gauze covering the insertion point. Make sure to grab the guide wire as seen. Don't fill the CVC lumens with saline before the procedure, but rather when it's in place, aspirate blood with one syringe, in this case the 2 cc syringe. Then inject saline from another syringe to avoid contamination with blood in the saline syringe. Suture through steri strips to avoid cutting fragile skin, for example in those with long-term steroid use. Then use a barrier film like Cavalone to protect the sensitive skin. Note that despite all our precautions, there is still a small rip of the skin when this drape is removed. There you have it. A few things we've learned along the way. The devil's in the details. Good luck.
Pneumothorax, and to ensure proper positioning of the catheter in the subclavian vein with its tip at the superior vena cava and right atrial junction. Of note, The SVC, right atrial junction, is located on a chest x-ray at the level of the carina.
Now grab that wire and start feeding it through the needle. The wire should advance fairly smoothly. If it does not, something is wrong. You should stop and reassess. You only need to feed as much wire as the catheter is long. Any more is unnecessary. If your guide wire is like mine, the second or 2-line marking on the wire identifies 20 centimeters, and so I advance until that mark is at the skin. And as you advance, watch the monitors for signs of ectopy. If you see that, then you are too deep and you should withdraw the wire a couple centimeters. From here on out, one hand should always be controlling the wire until it is out of the body. Otherwise, there is the rare chance it gets totally sucked into the vein, and that will be an embarrassing call to vascular or cardiothoracic surgery. Speaking of embarrassing calls, now is a good time to confirm placement of the wire. If you accidentally wired up the carotid, it's not too late. You can still remove it and hold pressure for several minutes and see if you can get away with it. But if you go to the next step and you dilate the carotid artery, you will need to call vascular. Here is how I am confident that I put the wire in the right spot. 1. The initial flash was dark venous appearing blood. 2. Under ultrasound, I saw the tip of the needle entering the vein and not the artery. See the ultrasound guided access video for more info. 3. The compass pressure transducer, if I'm using it, was reading a non-pulsatile venous level pressure. And 4. I see the wire traveling down the jugular on ultrasound. So number 4 is what I do next. Pick up the ultrasound and put it just over the wire. In short axis view, follow the wire down the jugular as it meets the subclavian. Then I do the same thing in long axis view. Unfortunately, our model doesn't have a subclavian, so the demonstration here isn't perfect. Leave a comment if you thought Dr. Franco should have let me put a center line in him for educational purposes.
So what's our next steps? So let's talk about successfully accessing the vessel now that we have the blood returned in our syringe. So again, like I said, many people will try to thread their wire at this point, but there's some common problems that you may run into. One of them is going to be losing blood return when you disconnect the needle from the syringe. Like you had great, blood return as you're trying to aspirate, but as soon as you disconnect that needle, the bleeding, it's not bleeding anymore, or you try to thread your wire and it just doesn't go. Again, not being able to pass the wire, so this can be caused by what we just talked about, or it may be that your needle is in the vessel and you're just hitting the back wall of the wire. So how can we improve the chances of success once we have our flash in our syringe here? So I'm going to talk about something called the vanishing bullseye technique, or also vanishing target sign, you may see. And so this is a technique you can do once you're actually in the vessel. So what we're going to do is we're going to advance our needle a little bit farther, even though we have flash. We're going to see our needle tip. It's going to go down towards the bottom of the vessel on our screen. As we advance it, we don't want to back wall or go through the vessel. We're going to go advance a little bit more, and we're going to see something like this. At this point, we're going to do that bullseye part. So we're going to put that dot in the middle of the vessel, making it look like a bullseye. So that's going to involve dropping our hand and putting that dot in the middle of the vessel so we have our bullseye. So now we're going to make it vanish. And to make it vanish, we're going to move our probe away from us. We're going to go forward a little bit, a couple millimeters or so. And we're going to do the same thing again. Make that bullseye. And then by bringing our hands back down again. Kind of do this generally 2 or 3 times with the goal. You've gone far enough. If the needle hand is now dropped the angle so much that that needle hand is resting on the patient. So this may take 2 or 3 times. So why do we do the vanishing bullseye technique? So here's a couple of advantages. Here I'll show you a quick video of me doing this. Again, through the skin, I'm at the vessel. Follow it forward. I'm about to puncture. You can see I had the tenting there, and now it's kind of rebounded. You can see it rebounding. So I'm through the vessel, so now I'm going to follow the needle tip down. There's my needle tip. And then I'm going to advance forward. And now I'm going to drop the angle of my hand, making that bullseye. Advance forward, drop my hand, making that bullseye there. So if you look, see how my needle hand is dropped. And so to the point that the hand that was previously holding the probe, I can now rest firmly on the patient, and I can pinch the needle between my index and middle finger while having that hand, my probe hand, secured onto the patient. I didn't put my syringe on too tight, so it's very easy to take off. So as I take off my syringe, I can now easily and immediately cover that needle with my sterilely gloved thumb. So this is going to prevent any sort of air embolization, and then also it's going to make it a much cleaner procedure. You're not going to have bleeding everywhere. And the entire time, though, because my left hand that's holding the needle now is resting on the patient, I should minimize any movement that occurs as I'm trying to move that syringe or before I get the wire in. However, let's just say I end up getting some movement even though I had my hand braced. Just compare the amount of wiggle room that we have for the needle to move before we run into trouble. So here we are between a steep and a shallow angle. So don't do this, but if you look, I don't have that much wiggle room before that needle goes all the way through the vessel when I'm steep. However, if my angle is shallow, like after the vanishing bullseye technique, I do have a lot more distance to go before that needle actually goes through and through the vessel. So it just gives you a little bit of margin for safety. It also gives you a nice demonstration of how the visibility of your needle changes depending on the angle of your needle to the probe. Let's say you have a steeper approach and you didn't back wall, but now you're trying the needle's firmly in the vessel, but now you're trying to thread the wire and you're running into trouble. So why is a shallower approach maybe a little bit better at times? So if we look, my needle tip is in the vessel with a steep approach, but even so, the wire still doesn't want to pass because it's hitting onto that back wall. However, if we use that more shallow approach, we're going to get more of a margin for error here because the wire is going to come out and it has a trajectory similar to the vessel. It's going to be more parallel or closer to parallel with the back wall of the vessel, and it just is going to generally go much easier. So again, if you have a technique that works for you and you're able to do it steeply and have good results, that's fine. But if you're finding that you're having problems or you're having difficulty threading the wire, this is, again, a nice technique that reduces the risk of that happening. Another little quick tip here, feel rhythm. So I'm an anesthesiologist by training, so I'll find any excuse to turn on my pulse ox beeps. It makes me feel better. But I would recommend that you turn them on during your central lines, because as you're advancing your wire, if you go a little bit too far and you get some PVCs, you'll be able to immediately hear that without depending on others telling you that there's active P. So this can be very useful. If you hear that steady beep, 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 and then all of a sudden you hear a beep, 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 just pull back real quick and nobody has to tell you, and it's fixed in a quarter of a second. So kind of, again, putting it all together, we'll kind of just go through the whole thing. So we picked up a probe. We're going to do our sanity check. Left is left. We're going to do our pre-scan. The vessel is staying in the middle of the screen. We found a nice spot. I'm going to have an entry site that's about the same distance from the top of the vessel back away from the probe. Give me that nice 45-degree angle. And I have my needle here. I'm going to enter the skin, and then I'm going to drop the angle of my needle. Find the tip, nice bright white. I'm going to bring that needle back up so that I know exactly what I'm looking for. In general, it's not a good idea to make big angle changes like this once the needle is in the patient, especially deep. However, I say this is one exception because we're about to stick a scalpel right here, and any tissue damage we do is really kind of a moot point. All right, so we found a needle tip. We know exactly what it looks like. Now we're going to carefully march it down to the vessel. The distance I move the probe and the number of times that it takes for me to advance and get to the vessel really depends on how easy it is to see the needle tip. So we have our tissue indentation here. We're going to follow it down. We're going to find our needle tip. Now we're going to finish here with our vanishing bullseye. My hand is dropped all the way down, so now I feel confident in being able to advance that wire. So that's kind of the main things I wanted to talk about for the ultrasound guided central line. I do want to go on just one more topic about dilation. I think this is also an area that people sometimes struggle with.
I want to briefly discuss the other potential central line access sites. They all use the same cylinder technique, so you don't have to learn too much more. We just demonstrated the right internal jugular. You could also access the left IJ with the same landmarks, but there is a greater chance of malposition because the catheter will need to make a sharper turn down the superior vena cava. Subclavian lines are also an option. The advantages of the subclavian are increased patient comfort and decreased risk of infection, but downsides are that this site is difficult to compress if you encounter bleeding, and there is an increased risk of pneumothorax. Subclavian lines are sometimes obtained blind, but ultrasound is becoming much more popular. Still, the blind subclavian is very fast to put in a trauma situation. If a FEM line is not possible, the subclavian is my next choice. For the blind landmark guided approach, put your index or third finger on the sternal notch, and then put your thumb on the prominent bump of the clavicle where it starts to bend toward the shoulder. Insert the needle next to your thumb and aim the needle at the finger on the sternal notch. Aspirate as you advance and you'll hit the vein. Here's the infraclavicular short axis view of the subclavian vein. And here's long axis. You can also get a supraclavicular approach by following the jugular down until it meets the subclavian, and then following the subclavian from there. Speaking of depths, for insertion depths of neck catheters, I place right-sided neck catheters 16 centimeters deep, and left-sided catheters I place 19 centimeters deep. I adjust if the patient is very short or very tall. There are formulas that predict optimal depth based on height, but I don't bother with them. Remember, if a line is too deep, you can withdraw it, but if a line is too shallow, you can't advance it further without replacing it. In my experience, I rarely put lines in too deep. Finally, the femoral line is the archetypical crash line. This line has the highest rate of infection and is not comfortable to have in, but you can place it while people are crowding around the top of the patient. Remember, the vein is medial to the artery, so if you can feel a pulse, aim medial to the pulsation. But often these patients are crashing and do not have a pulse, and in that case, my favorite landmark to use is the pubic tubercle. That's the bony prominence off of the lateral aspect of the pubic bone. Measure 2 finger widths lateral and 1 finger width inferior to the tubercle, and that's where you should stab. Hub the line when you insert it.
The optimal tip location is in the lower superior vena cava or the CAVOATRIAL junction. This has several reasons. The blood flow is high enough to dilute toxic infusions like potassium chloride or chemotherapy. The risk of thrombosis is low, and you get an accurate CVP and central venous saturation measurements. And the catheter tip is unlikely to perforate the vessel wall in this location. If the line is only to be used a couple of days and we don't need CVP measurements, we sometimes accept an earnest tip placement. For example, it has been shown that infusions running in a retrograde jugular line never shoots up towards the brain more than a few millimeters from the tip. It's generally safe. A normal-sized adult will usually be well served by a 15 centimeter catheter on the right and a 20 centimeter on the left. Insert the full length of the catheter. You can always retract it later, but it's not possible to push it in further if you need to. A special case would be the arrhythmia-prone patients. You don't want to provoke a ventricular tachycardia by poking the guide wire into the heart. Sometimes one size doesn't fit all. Is there perhaps any radiology available? In this case, the patient had an unexpected long distance from the right IJ to the heart and needed a 20 centimeter line on the right side. Whereas this 16-year-old had a severe thoracic deformity and needed a 10 centimeter catheter. But you also have to be clean. Wash your hands like a surgeon scrubbing up for theatre. Sterile gloves and gown, a hat and a face mask are mandatory. Next, prep the skin while the patient turns his or her head to the contralateral side. Start with a large area and make it smaller with each pass. What you want to avoid is making all this effort and then taking a last swipe from the outer perimeter to your puncture site, potentially pulling in crap. This is not sterile until it's dry, and the drapes won't stick to wet skin. While the patient is drying, you prep your tray. When you drape the patient, allow for a large enough area to access the puncture site, the supraclav fossa, and a backup location. I find that the adhesive two-parted drapes are extremely useful to achieve this. And if you're placing a left-sided line, you may want to include the supraclav fossa on the right side. The drapes should be large enough so a stray guide wire doesn't risk hitting a non-sterile area. Some guidelines call for a full body cover or a sterile sheath under the patient. I personally don't see how this is necessary, but you know, follow the guidelines and don't fight the system over this. Note how I fold the top of the drape in order to not completely cover the patient's face. It can get pretty claustrophobic inside there otherwise. This patient has extremely sensitive skin due to chronic steroid medication. You can easily rip the skin apart if you're not careful when you remove the adhesive drapes. We suggest that you use gauze pads for protection, and similarly, gauze can be used to cover wound dressings or other catheters that will be covered by the adhesive drapes. Here's another alternative, how you can minimize the adhesive area, which can protect sensitive skin. Next, optimize your ergonomics. I never stand at the head of the bed anymore. The reason? It's cumbersome. Stand by the side of the patient's bed where you have your equipment easily accessible and the ultrasound machine within your line of sight, lined up with your in-plane cannula. You also have equally good access between the subclav and the IJ if you use the oblique technique. This also goes for in-theatre.
There's been a lot of research looking at this, and what's interesting is that ultrasound has been found now to be more sensitive than chest x-ray in the diagnosis of pneumothorax, especially in the supine trauma patient. Now let's learn how to perform the ultrasound examination for the pneumothorax detection. Here we have the high-frequency linear type array probe positioned on the anterior chest wall at about the mid-clavicular line, looking into about intercostal space 3. Now, in most cases of pneumothorax with the patient supine, the air would be predominantly seen in this area. Findings of a lung in a long axis type configuration. Superior rib to the left, inferior rib to the right. Notice that the ribs cast shadows posteriorly due to the inability of the sound waves to permeate the hard calcifications of the rib. We see the chest wall, and as the patient breathes, we can see white comet tails or linear lines, vertical lines coming off the pleura down deep into the lung. So that will be the normal finding of a lung on long axis configuration. Here's a way to document that the lung is up to print out for the chart is to put M mode, and generally what we do is locate it so the M mode cursor is down right at the pleura. And what we see is the classic seashore sign, or waves on the beach. If we look anteriorly, we'll see the classic waves, or no motion of the chest wall, and below that, deep to the pleura, we'll see the positive motion of the lung making up the beach. So let's take a look at a pictorial showing a pneumothorax in a long axis view. We see here that the parietal pleura is now split from the visceral pleura, which is attached to the lung, by a layer of air shown by the yellow color. It's the splitting of the parietal and visceral pleura that now causes a lack of lung sliding, and instead of the opposed visceral and parietal pleura sliding back and forth as the patient breathes, all we see is a single line, the parietal pleura, with a lack of vertical comet tails coming off the back. Here's an ultrasound image taken from a patient who was stabbed to the left chest and who had shortness of breath. What we see here is a long axis view of a pneumothorax. Let's take a look at the chest wall anteriorly, and right below that we see the parietal pleura, the single white line located directly inferior to the ribs, but notice the classic lack of the lung sliding. All we see here is a single white line that fails to slide back and forth as the patient breathes. Notice also the absence of the vertical comet tails. Here's another image here is repeating horizontal air lines from the pneumothorax. To document the absence of lung sliding and the presence of a pneumothorax, we'll again turn to M mode. If we put the M mode cursor down on the pleura, what we'll see is a set of linear repeating lines. This documents no motion of both the chest wall and of the lung, making up a finding known as the barcode sign. Here's a pictorial showing an interesting finding, the signature of an incomplete pneumothorax known as lead point. And what we see is an incomplete pneumothorax with air collecting to the superior aspect of the image to the left, thus splitting the parietal from the visceral layers and causing an absence of lung sliding superiorly. However, as the lung is coming up against the chest wall to the right or inferiorly, that's where we'll see the presence of horizontal lung sliding and the presence of the vertical comet tails. Here's an ultrasound image showing the lead point, and what we see here is the lung sliding to the right, the area where the lung touches up against the chest wall, and to the left, the area of absence of lung sliding, telling you there that air has collected between the visceral and parietal layers.
Don't forget the flush. You have to do it before you get all sterile. There's nothing worse than getting gloved and gowned up and realizing you have to start over because you didn't put any flush in your kit or in a sterile basin. Don't forget the flush. You got to make sure your guide wire is ready to use. You got to make sure that J-loop and that tip of that wire is hidden by that conical plastic piece. And you got to make sure you understand how the wire is to be fed, whether it's going to be one of those ones you can feed with your thumb, or if you actually need an exposed piece of wire to grab between your index finger and your thumb to advance it through the needle. On that same note, you got to have your guide wire on your sterile field within an arm's reach of wherever you're doing your procedure. You don't want to have to, turn around and grab it off the table or have someone hand it to you. This is a moment where you should be as still as possible, and you shouldn't have to move too much to grab your guide wire. Remember, there are certain patients that should just not be receiving a triple lumen catheter. These are people that may need a large amount of volume infused in a short period of time. People like your trauma patients, your burns, GI bleeders, or anybody that's coding. Instead of placing triple lumen catheters in these people, you should be putting cordis catheters, which you can float a triple lumen through, or a trauma one. If you're placing a cordis catheter, no matter how emergent it is or no matter how quick the line needs to be put in, you got to take a couple seconds before you start to make sure that dilator is within the center of the cordis catheter and that it's snapped in place. You don't want to have the guide wire in the patient and you have to take both hands off of it to assemble your cordis catheter before you can place it in.
Landmark guided subclavian central lines need not be a scary technique, and they are both useful and simple to perform. Always keep these key points in mind, many of which are generic to all central line placements. Thank you for watching, and I hope this helps someone, somewhere, sometime.